Shall I
Yeah,
start,
good
sir?
evening, everyone. Yes, Vinod, today we'll be talking about second part of nutrition, where we will be discussing about enteral and parental nutrition, indications, contraindications, complications, and various methods where we give enteral and parental nutrition. Yes, Vinod, start on.
Uh, uh, Good evening to everyone. And today's topic is on second part of the nutrition. And today's talk is on history of nutrition and various types of nutrition and the nutrition specifically in critical illness. And the importance of nutrition has been even started before 3,500 years ago, during which time they have initially started with wine, milk, and whey as the nutrients. And the first tubes for providing the nutrition was used by Capivasius or the hollow tubes, and later leather tubes were used by Boerhaave, and the Sedilet was the first person uh, um, to, uh, to do the gastrostomy. And there are various two types of nutrition, basically divided based on how we are providing the nutrition. And enteral nutrition is the nutrition in which we are providing the nutrition through the gastrointestinal tracts. And the parental nutrition is the nutrition in which we provide the nutrition in the elemental forms through the vessels. And there are different types of nutrition mechanisms, techniques through which we provide the enteral nutrition. There are sip feeding and tube feeds like nasogastric and nasojejunal tubes, and the surgical tubes like feeding gastrostomy and feeding jejunostomy. And through parentally, we provide through peripheral lines, central lines, and peripherally inserted central lines. And the various benefits of enteral nutrition are basically it is so cost effective, and it is physiological, in which we provide we maintain the gastrointestinal integrity, and it is easy to administer. And according to Lofgren MD et al., initiation of nutrition early, like within 48 hours after a major clinical event, in the patients who are hemodynamically stable and having a functional GIT, provides an outcome in good outcome in terms of morbidity and mortality. And it also reduces the incidence of fistulas formation, and there is no effect on anastomotic leaks. And basically, the choice for the selection of enterical feeds depends on the patient's organ function and the specific nutrient the patient requires and the cost of the specific products. And basically, the commercial feeds which we generally have 1 kilocalorie per ml, and in the specific conditions, the calorie might be increased to 1.5 to 2 kilocalories per ml. As I said, the standard formula contains the caloric density as 1 kilocalorie per ml, and
Vinod,
protein in which. Hello, sir.
Stop. I don't think there are any enteral feeds which give you 2 kilocalories per ml. I think the ones that are there, most of them that we use are 1 kilocalorie per ml, and in exceptional circumstances where you want to reduce the fluid intake because of cardiac or renal or hepatic situations where you need to restrict the fluid intake, then you can give 1.5 kilocalories. I don't think there are any feeds which give you 2 kilocalories. Niranjan, you have to unmute.
Yes, sir, I agree. The standard parental nutrition which we get through pre-prepared this thing maximum is 1.5. I think 2 will have to be specially prepared. I don't think there are any bags which provide 2 kilocalories per ml. Lakshman, sir?
Yeah, I agree. Yeah.
Yes, Vinod.
Yes.
Anyone else? Any clarification?
Other clarification, you go back to your previous slide.
Yes, sir.
See, you have put all the factors which are very important. The patient's general condition, patients in renal, pulmonary, hepatic, all the GI and cardiac as well. So those are things which is, and also you also have to take into consideration how you are feeding. For example, whether the upper gastrointestinal tract is being used, or mid GIT or lower GIT with colonic, this one is being used. So all of these things. So for example, if you are using the upper GI tract, you can give semi-elemental diet. But if you are using mid and lower GIT, then you may have to go for a purely elemental diet. So these are things again which are to be considered before you make choice of enteral formula.
Okay.
Yes, go on,
Carry on.
Yes. Yes. And the standard enteral formula contains 1 kilocalorie per ml of caloric density, which contains around 14% of proteins and 60% of calories through carbohydrates and 30% of calories through fats. And osmolarity generally it will be around 300 milliosmoles per kg. And in a modified enteral formulas, in a specific conditions like fluid restricted patients, the caloric density is increased to 1.5 kilocalories per ml. And the proteins in a critically ill patients, we increase it to 25%, which is 14% in a standard formula. And when there is an impaired absorption because of decreased absorption area of intestines, we will give a protein in a peptide forms. And fats is increased to 40% in a patient with a pulmonary failure, and we also increase the omega-3 fatty acids and decrease the omega-6 fatty acids in a patients with ventilator who are on acute respiratory distress syndrome patients. Can I continue, sir?
Yes, continue.
Yes. And various types of feeds, according to Thomas David et al., are feeding modules and polymeric modules and specialized formulas. And feeding modules are the feeds in which we provide a specific type of energy, like specifically carbohydrates or specifically proteins or specifically fats. In a polymeric modules, we provide these energy modules in a combinations. In a specialized formulas, these are breakdown into elemental forms, and they are provided in elemental forms. These are called as specialized formulas. And indications for enteric feeding. Generally, these enteral tubes are provided in patients who are unconscious and problems with the swallowing, like stroke patients and motor neuron disease patients, and physiological anorexia like liver diseases and malignancies. And in upper GI obstruction like esophageal strictures, and in patients who require a nutritional requirements excess like cystic fibrosis and renal disease patients, and patients with the psychological problems like depression and anorexia nervosa. And contraindications to the enteral nutrition are intractable vomitings and refractory diarrhea, high output intestinal fistulas, and bowel ischemia, and diffuse peritonitis, severe shock, and GI hemorrhages, and severe short bowel syndrome, and severe GI malabsorptions.
Pawan, stop there.
Vinod.
Sorry, Vinod, can please stop. Two things. Niranjan, can I?
Yes, sir, please, sir.
Yeah. See, two things. One is high output intestinal fistulas. I agree that initially, when you note that there is high output intestinal fistulas, you don't feed them. But once the patient sepsis and other things are stabilized, you get the anatomic location of the fistula by doing contrast studies, fistulograms and things. Most of the time, you will have a distal bowel which is probably healthy, provided there are no strictures, further fistulas, and further communication with the intestine or with the peritoneal cavity. You can then use what is called as the feeding fistuloclysis. You can use the fistula output and add your enteral feed to that, but this has to be done in as sterile condition as possible, and you can feed them. Other thing is short bowel syndrome is not a contraindication to enteral nutrition. What happens is because of short bowel, whatever you are going to give will not be sufficient. So you will have to supplement with TPN. And if you continue feeding, there is adaptation of the bowel, and the amount of TPN support that you require, you will keep coming down. You can also use other modalities to decrease the output from the GIT, that is, fistula, either a fistula or in terms of diarrhea. You can give them high dose PPIs. You can give them long acting octreotide and all these things to reduce, and also loperamide to reduce the transit of, increase the transit time and reduce the output from the fistula. And the bowel also adapts over a period of time. They may not completely be comfortable with enteral feed, but the dependence on TPN will come down as the days go. So it's not a contraindication.
Yes, okay.
Yes, sir. Anybody has any questions?
Sir, I have one doubt, sir. Hello, sir.
Hello?
Can you hear me?
Yeah, tell me.
Sir, in case of paralysis, like post-operative ILS, can we give enteral nutrition, sir? Because patient is already in ILS.
Yeah, if it is full-blown ileus, you can't, because the patient will continue to vomit, no? So it has to be a functional gut. So in full-blown paralytic ileus, the gut will not function, but you can start the feeds early. There is a difference between starting the feeds early. You can start as early as up to 6 hours after surgery when the small intestine recovers. That is 6 to 8 hours is the time frame when the intestine recovers. So you don't have to wait for the bowel sound stop here and start feeding. But when there is a full-blown paralytic ileus, you can't, if patient is having vomiting, distension and all that, you can't continue to keep on feeding. Maybe in selective cases, you can start off with liquids. If patient is able to tolerate, then you can continue.
Okay, sir. Okay.
Sir, any other answer, sir, for that?
No, I think you're right.
No, I think that's fine. Please go ahead.
Yeah.
Can I continue, sir?
Yes.
I would just like to add for that, Niranjan,
Yes, sir.
that the ileus is mostly in the colon and the stomach.
Colon, yes, sir.
And small bowel ileus is either it doesn't occur or is extremely short. And so if you have access to the small bowel, like feeding the jejunostomy, you can feed them the very next day after surgery. Yeah.
Vinod, one more, you said very clearly about the gut integrity, maintenance of gut integrity by enteral feeding, which is very important. That is, it continues to maintain the mucosal blood flow, so which is very important. So, but what is the other extremely important corollary to this, maintenance of gut integrity? Okay, so basically, one of the theories for septicemia and sepsis is translocation of bacteria. Okay, so if the mucosal integrity is lost, if the blood supply gut is not being used, the tight junctions in the mucosa, which will prevent the translocation of bacteria, will be lost. So the bacterial translocation happens, and that can drive sepsis. So not only is the gut integrity important because you may want to maintain the mucosal blood flow and also the absorption facility of the gut, but also gut plays an extremely important role in immune and in the translocation mediated infection, which can turn out to be septicemia. So you can to a large extent prevent it by starting early feeding.
Yes, sir.
Carry on.
Yes. And various complications with enteral tube feedings is tube-related or malpositioning and displacement and blockage, and gastrointestinal complications like diarrhea, nausea, bloating, and constipation, and metabolic like electrolyte imbalances and vitamin deficiencies and drug interactions, and infections like because of hand contamination, maybe because of exogenous and endogenous.
Wait. Tube related, one more important complication is aspiration.
Yes, sir.
Continue.
See, the important thing is that you should not presume that once you put the tube that it is in the place, right place, and carry on feeding. You have to watch the patient and see how they are doing. And I had to operate on a patient who had a peg put in, and there were about 15 liters of inspissated and cake-like material in the general peritoneal cavity. They kept on feeding this patient, and there was leak around the peg tube, a gastrostomy tube, and nobody bothered to see. Patient's abdomen had become very tense, and there was a sign of peritonitis when we operated on this patient. So it is very important. Enteral feeding is good, provided you deliver it safely. So tube-related complications are not uncommon. You have to be very vigilant about it.
Yes.
Continue.
Can I continue, sir?
Yeah.
Yes. And enteral nutrition, basically we decide whether to go for a surgical tube or a regular tubes, basing on the duration of requirement of the enteral nutrition. If it is less than 4 weeks, generally we go for the non-surgical tubes like nasogastric, nasoduodenal, and nasojejunal tubes. And if it is more than 4 weeks, we require surgical tubes like gastrostomy and jejunostomies. And nasogastric feeding, this is done by using rice tube. Basically, the normal length of a tube is around 110 to 130 centimeters, and the appropriate length to which it should be inserted can be defined using a next rule or a NEMU rule, in which the length is measured from nose to ear and ear to giphisternum in adults, and in pediatrics, nose to ear and ear to midpoint of epigastrium to umbilicus. An ideal method to insert a rice tube is sitting with a neck flex position and Fowler's position. And in insertion of nasogastric tube, generally we advise inform the patient how we are going to insert it, and then we'll advise the patient to be in Fowler's position, and we provide anesthesia in the nostrils with the lignocaine gel, and it also helps in decreasing the friction. And we provide a little amount of water through the mouth, and we'll advise the patient to swallow during the tube is inserting. Once the tube is entered in the appropriate length, we will confirm using the auscultating with stethoscope in the epigastric region by pushing air, and also looking for the reflex of gastric contents in the tube, and aspiration of secretions, and testing with the litmus paper for the pH. And there are various sizes of the tubes, of which are coded with the particular colors, and most commonly used tubes are green and orange, which are 14 and 16 sizes respectively. The indications are of these tubes are basically to provide the medication in unconscious patients, or in a patient who cannot take through orally, like stroke patients, and to provide the nutrition in the patients like same as a patient of a stroke or unconscious patients, and GI bleeds, and in paralytic ileus, the role of nasogastric tube is still in query, as it, according to few studies, it says that it will hinder the movements if you initiate early. And contraindications for the nasogastric tube are anatomical deformities and non-functioning GI tracts, and large amount of gastric aspirate, and intractable vomitings, and maxillofacial traumas and surgeries, and esophageal tumors, and basal skull fractures, and severe gastroesophageal reflux diseases. And because of the tubes, there are complications like epistaxis, nasal necrosis, esophageal strictures, and erosive esophagitis, and misplacement, which leads to aspiration. Can I continue, sir?
Yeah.
Continue.
Nasojejunal feeding. In this, the tube generally contains very fine bore, which is around 6 to 10 French gauge. Basically, these are indicated in a patients with a severe gastric reflux or unconscious patients, and in a delayed gastric emptying conditions, and also in the patients with a proximal leak. And when the appropriate length is measured from nostril to ear and ear to anterior superior iliac spine. And these tubes are generally stiffened by providing the stylet, and these are passed through the pylorus under fluoroscopy or endoscopy. The indications are gastric reflux or gastroparesis, and requirement to bypass the duodenum, and upper gastrointestinal fistulas, and perioperative feedings. And absolute contraindications are basal skull fractures and tracheoesophageal fistulas, and relative contraindications like upper GI obstruction, nasal polyps, coagulation disorders, and esophageal strictures. And these tubes generally contain 3 lumens, of which one is for gastric aspiration lumen, and one is for jejunal feeding, and one is for air lumen. Shall I continue, sir?
Both the feeding jejunostomy and Ryle's tube placed or nasogastric tube placed for feeding purposes. Apart from what you said about confirmatory, this one you need to also get a chest X-ray to confirm the position of the tube before you start feeding. I think that's very important. Okay.
Yes, Vinod, continue.
Feeding gastrostomy. These are surgical tubes. Basically, the technique of like Stam and vaginal were used. These techniques are used to place the tube into the lumen by procedures of open method or laparoscopic method and endoscopic method. These are generally indicated in neurological problems and esophageal atresia and post-corrosive injuries because of acids. And this is the technique, Stam technique, in which we provide a purse string and will stab the lumen with just 11 number blade and will insert the tube. And in these have leakage around the site. So to prevent the leakages, they provide they have evaluated another technique called vaginal techniques, in which the tunnel is created serosally, so the leakage will be minimized. Open method of feeding gastrostomy, in which we given laparotomy incision in upper supraumbilically, and we find out the place at which the tube to be placed, and we provide we insert a tube through the anterior abdominal wall, and we provide given post-string sutures at the site of over the stomach, and will stab the inside the purse string, and will insert the tube, and will tighten the purse string, and will fix the stomach to the anterior abdominal wall by intermittent sutures. This is the open method. Similar to open method, in laparoscopy, we enter through the umbilicus, and in umbilical through the umbilicus, will in our through our guidance, under our observation, we'll keep another incision or trocar in left lumbar or left hypochondric region, and through which through the loop through the bowel, through which we'll extract the stomach outside, and will with the help of Stam technique or vaginal technique, we insert the tubes and we'll strengthen it, and we'll fix to the anterior abdominal wall. This in the first image, we are selecting the stomach at the point at which we have to place, and we have extracted out, and we are giving a purse string suture, and we have inserted the tube, and we are fixed it to the anterior abdominal wall. Can I continue, sir?
What are the complications of these techniques?
Next it is there, sir.
Sorry?
After endoscopic technique, I mentioned the complications.
Okay.
PEG tubes. These are percutaneous endoscopic gastric tubes. These are basically recently most used tubes, as these are minimal surgical technique, as this is provided through pull through technique or push through technique or introducer technique, in which the patient in supine position will pass the endoscope, and under the transsimulation of light, we incise the abdomen and we will enter into the stomach through a guide wire, and this guide wire is pulled into the mouth through the bypass along with the
biopsy channel.
Along with through the biopsy channel, and through this guide wire we introduce the G tube, which will be pulled through the anterior abdominal wall, which is called as pull through technique. If the tube is pushed through the abdomen, this is called as push through, and with the help of introducer, then it is called as an introducer technique. And these are basically indicated in the stroke patients, which in them, when there is a prolonged usage of the tubes for the requirement of nutrition, and unconscious patients, and palliative measures like esophageal tumors, which cannot be surgically treated. Contraindications are basically hemodynamically unstable patients, severe ascites, sepsis, and total gastrectomy patients, and gastric outlet obstruction patients. Complications: aspiration pneumonia and organ injuries, necrotizing fasciitis, buried bumper syndrome, granuloma formation, bleeding, and periosteomal leakage.
What is that? Buried bumper syndrome.
Sir, the tube which is inserted sometimes may come out from the stomach, and it might be in the abdominal wall, and if you doesn't take the care, the contents which the nutrition which is given will be leaked into the abdomen.
That is what Ravi Shankar sir was mentioning.
Yes, sir. Continue, sir. Any questions?
Okay. Go on.
Yes.
Wait. Among all those gastrostomies, which one will you prefer, and why?
I'll prefer PEG tubes.
Why?
As it is a minimally invasive surgery, sir, and
all even laparoscopic gastrostomy is also minimally invasive.
But sir, it requires general anesthesia.
Yes, it is least invasive. Yes, and lesser amount of complications when compared to feeding gastrostomy.
Yes.
Anyone else has any questions? Okay, Vinod, continue.
Yes. Feeding jejunostomy, it is basically used for the patients to prevent the aspiration, like in unconscious and stroke patients. The technique is similar, like a STAM technique and a Wisner technique, by using the procedures like open laparoscopy or percutaneous endoscopic technique. And the basic indications for as I said, gastroparesis, gastric outlet obstruction, and row invasive surgeries. And contraindications like hemodynamic instability, coagulopathies, and abdominal wall necrosis, and previous necrosis in the gastrostomy areas. And enteral nutrition, there is not a definite indication like a requirement of bowel movement for the initiation of enteral nutrition. And gastric residual of around 200 ml is an indication to stop or adjust the infusion of enteral nutrition. If a bowel resection, in bowel resections, if there and the intraperitoneous fistula, if there is a less than 500 ml of leak, then start fluids, nutrition within 24 hours. Okay. Continue, sir.
Anyone has any questions till here?
PGs are not asking any questions. I hope you all come read and prepared for it. Okay, continue, I think.
Parental nutrition. parenteral nutrition is a form in which the nutrition is
No,
provided.
Vinod, you didn't tell us about how you start enteral nutrition, how you build it up. I think a practical point, it's very important.
Yes. You have just mentioned one line there. You're talking about refeeding and all later?
Yes, sir. After TPN, I started about refeeding syndrome.
Answer Ravishankar sir's question.
Yes. Sir,
Anybody else? Indraja, tell us how you start enteral
Sir,
feeding, how
we
you
can-
build it up.
So we can start at 10 to 20 ml per hour, sir, and we can increase up to 75 ml per hour.
Can't just give a, sir, just.
Why only 75 ml?
Indraja?
I'm not sure, sir.
See, I think the main thing is, I think you're right. You start with the 10 to 20 ml of aliquots every hour. Initially you give either, just water or glucose solution. And then once you are happy that the patient is absorbing, there is no distension, then you can gradually increase it and reach the requirement in terms of depending on the number of days you need to give them. So you can go up to 100 ml per hour. Many times there are many different methods and different theories and also philosophies to kind of mimic the day-to-day, because through the night nobody eats. So people say you give the feeds during the day, during the nights you can switch it off so that the patient sleeps. And then there are people who give them through the night also. So I don't think there is any one right way or wrong way. But if at all the patient is eating also and you are supplementing, then what you can do is to during the days you allow the patient to eat and during the night give the supplementation. If the patient is not eating at all, or you want the entire requirement to be given through the enteral feed, then you can go up to 100 ml, which will be about 2.4 liters per day. And then the calorific requirement you can adjust depending on the cardiac failure, renal failure, hepatic and other fluid electrolyte balance status. You can give them the fluids which will contain 1 to 1.5 kilocalories. And then you can also add other nutrients as well. Usually they say, as you said, 14 to 20% protein, 50 to 60% carbohydrate, and 30% fat is the usual formula that you give. And then as and when the patient is eating and you are reducing, you can start reducing the enteral feed slowly and then stop as and when the patient's normal eating takes over.
Yes. Okay, sir.
Anything to add, Niranjan?
Nothing, sir. Same, sir. We'll continue if no other questions.
yes. Parenteral nutrition. In the parenteral nutrition, we provide the nutrition in elemental or pre-digested form, as proteins in amino acid form, and carbohydrates as dextrose, and fats as lipid emulsions, and electrolytes, vitamins, and minerals. And these parenteral nutrition basically provided through intravenous route, and generally the anticipated duration should be at least 7 days. And the various types of parenteral nutrition, like peripheral line and peripherally inserted central lines and central parenteral nutrition. And the best way to provide the nutrition in centrally is, in an elective case, it is a subclavian vein, and for trauma cases, it is an IZD.
See, you're wrong. There's Hickman line is not a PIC line. Hickman line or central line. Okay. So PIC line is different. Hickman lines are central lines.
Okay.
Okay. Right.
I think he has put it for central catheter. He has clubbed them both.
Yeah.
Common indications for the parenteral nutrition are failed enteral nutrition and in the initial phase of severe acute pancreatitis and a short bowel syndrome and a mesenteric ischemia and a prolonged paralytic ileus and small bowel obstruction and GI fistulas in which the output is around greater than 500 ml, and when there is a distal bowel is not normal.
Distal bowel is normal. It is not. Distal bowel is not normal.
No, if it the distal bowel is not sufficient.
Okay. You are giving parenteral nutrition. Yeah, correct. Okay.
And contraindications when there is a functional GI tract and the patient is taking the oral diet. And to decide whether to give a peripheral or parenteral, generally, if it is less than 2 weeks, you'll go for a peripheral parenteral nutrition. And if it is greater than 2 weeks, we can provide through the central lines. Central venous actions. These central lines are non-tunnel and non-cuffed catheters inserted via subclavian or internal jugular or femoral veins. And PIC, these PIC lines are peripherally inserted central catheters. These are basically inserted via basalic or cephalic or brachial veins, which are large veins in the peripheries. PIC lines are the veins which are generally inserted from the periphery, and these are lines reach till the distal part of the superior tip rests in the distal superior vena cava. And these are basically used for long chemotherapy regimens and for extended antibiotic therapy, like in conditions like endocarditis and osteomyelitis. Peripheral parenteral nutrition. These are basically for a short period of duration, as I said, for less than 2 weeks, and try to avoid the lower limb veins, as these have chances for a production of phlebitis. And there are 2 types of peripheral placed catheters. There are plastic cannulas and Teflons, and these are into the basalic or cephalic veins. Most common complication is the phlebitis and infection and displacement.
Hello?
Vinod? Vinod?
I think we lost him. Vinod?
Hello? Somebody ring him and ask him to reconnect.
Yes, sir, I'm calling.
He's connected, on this.
Vinod?
Yeah. He should log in again. He's gone offline now. Yeah.
So the important thing of the peripheral TPN is when you are giving peripheral TPN, you should use a dedicated line. You can't use that to give fluids, IV antibiotics, painkillers, and all that. The one line, if you are giving peripheral TPN, use it only for that. And it has to be inserted under absolute sterile technique, using sterile gloves, clean the area properly, insert it, and then fix it properly. And you should have a transparent dressing so that you observe for presence of superficial thrombophlebitis or superficial infection. And usually these intravenous catheters are rotated every 3 to 4 days, depending on and you do not use the very hyperosmolar solutions. Usually about 700 to 800 calories can be given through the peripheral route. Through using the
large bore cannulas.
Yeah, large bore cannulas. And you don't use very hygroscopic and hyperosmolar solutions in this peripheral TPN. Vinod, are you back?
I think he's back.
Lakshman sir, anything to add, sir?
No, not really. Continue. Yeah. Vinod, I think, is back. You unmute yourself, Vinod.
Yes. Sorry,
Yeah.
sir. Some signal issues.
Sure.
Yeah, okay. Start sharing your presentation again.
Yes. Contraindications to peripheral parental nutrition is a significant malnutrition, severe metabolic stress, and the prolonged requirement of nutrition and fluid restriction and renal or liver compromise. Can I continue, sir?
Yes, please continue.
Yes.
I mean, these are all relative contraindications. I think there is nothing very
No,
specific about
absolute.
it. Absolute contraindication. Okay.
Okay. Yes.
Yeah. Why would when you have to feed somebody for malnutrition, why are you saying it's a contraindication?
So, in a significant malnutrition, the nutrition which we provide through periphery, which won't be sufficient.
Correct.
Why? But it's not a contraindication, right?
Oh,
It's not a
Anybody else?
contraindication.
It is.
Anybody else?
hello.
Indraja, anyone?
Sir, if we are giving in severely malnourished patients, there is a chance of redistribution of electrolytes within the
Refeeding syndrome.
Refeeding.
Yes, sir.
All right. So look up
Yes, sir.
about it. That's one of the things. But it's not an absolute contraindication. You must be aware of it. You must know how to deal with it. All the things that you have mentioned are relative contraindications.
Okay.
All right. And not really absolute contraindications. Yeah. Go ahead. Yeah.
Because if you don't have any other method, you at least have to give peripheral nutrition in them.
Correct. Yeah.
The compounding methods, which mean the combination of material in total nutrient admixture will provide dextrose.
One second, this thing might switch off. You have only 10% battery. Connect it to something.
Yes, sorry.
Yes, continue.
Yes. In total nutrient admixture, we provide the nutrition, the required calories in three forms, like dextrose, carbohydrates, proteins, and fats. And in 2-in-1 solution, we provide dextrose and amino acid together, and lipids, if required, in a separate piggyback or intermittently, like as a required source for essential fatty acids. TPN. This total parental nutrition is a support in which glucose, proteins, fats, and vitamins, electrolytes, and trace elements which are required for the basic body maintenance are provided, and it is generally indicated in the patients whose GI tract is not functioning, and in the conditions like flare-up Crohn's disease, ulcerative colitis, short bowel syndrome. And it is provided basically in the central or in the peripheral, like central parental nutrition and peripheral parental nutrition. And the basic difference between the central parental nutrition and the peripheral total parental nutrition is the osmolarity. In central parental nutrition, the osmolarity is around 1500 to 1800. In peripheral, it is around 700 to 900. And the glucose, the carbohydrate concentration is around 40% in central parental nutrition, and it is 12 to 13% in peripheral parental nutrition. This is because in the peripheral parental nutrition, the lines were very small, and it takes time to dilute the fluid which we are giving. So, because of the carbohydrates, the chances for phlebitis increases. And these are the bags in our hospital which we are using for central and peripheral. These contains glucose around 42% in the central line and glucose around 13% in the peripheral line. And the energy provided by the central line is around 2200 per bag, which is around 2 liters. And in the peripheral line, which is around 1.5 liters, provides around 1000 kilocalories. Can I continue, sir?
Yes, Vinod.
Yes. Lipid emulsions provide the calories and prevents fatty acid deficiencies through TPN. And basically, these are provided around 25 to 30% in the total requirement of the energy per person per the day. And essential free fatty acid deficiencies may develop within 3 weeks when 2-in-1 TPNs are used. Proteins, these are provided around 0.8 to 1 gram of protein per kg per day. In a critically ill patient, we provide around 1.5 gram per kg. And in a chronic renal failure patient, we decrease it to 0.6 to 0.8. And for a patient who undergoing hemodialysis, we provide it to 1.2 to 1.3 gram per kg per day. And carbohydrates are provided in dextrose monohydrate forms, and which is around 40 to 70%. And it can be utilized maximum up to 5 to 7 mg per kg per minute. And if provide an excess carbohydrates, it leads to hyperglycemia and hypertriglyceridemia. And the prolonged uses of carbohydrates leads to the prolonged continuous hyperglycemia. This continuous hyperglycemia leads to suppression of the liver. And when the suppression of liver prolongs, it may lead to the liver failure. Sir, can I continue, sir?
Yes. Anybody has any questions? Continue, Vinod.
Yes. TPN contains all the elements with electrolytes which are required, mainly sodium, chloride, potassium, magnesium, calcium, and phosphate. And never add bicarbonate to the TPN solution as it precipitates the calcium. And never add an extra calcium as it precipitates the phosphate and leads to the calcium phosphate. And always start adding the phosphate and later calcium. And also TPN contains most of the trace elements except iron, as it breaks down the emulsion and leads to the separates the TPN elements. And vitamins, water soluble vitamins are all present, and almost and all the lipid soluble vitamins are also present except vitamin K, and which should be provided additionally. Can I continue, sir?
Yes.
The TPN should be preserved in the at room temperature, and once the TPN has started, it should not be there is no medications or no IV drugs should not be added into the TPN. And always verify correct placement of a central line or PIC line by X-ray. And start TPN slowly at the rate of 40 to 60 ml per hour and gradually increase it to 75 ml per hour until maximum infusion rate. Initially, we should observe the vital signs. And
why is that? Why is that?
So,
why is that? You said in start off slowly at 40 to 60 ml per hour.
Yes, sir.
Why do you have to start off slowly?
Sudden hyperglycemia and sudden fluctuation in sugars, electrolytes, and this will happen.
What is it? It is again the same refeeding syndrome.
Yes.
Yeah. Continue.
Yes. Initially, blood sugar should be measured every 6 hourly, and daily measurement of weight and strict input and output monitoring, and decrease TPN solutions gradually to prevent sudden hypoglycemia, as the liver is in because of continuous hyperglycemia, liver is in compromised position as it cannot start immediate production of sugars from the gluconeogenesis and glycogen breakdown, and change the TPN sets for every 24 hours. And assessment of body condition after starting the TPN daily we should measure glucose levels in the body every 6th hour to 8th hourly, and at least twice a week LFT, electrolytes and renal function has to be done. Weekly pre-albumin, PT, APTT and nitrogen balance has to be done.
And also prior to starting TPN, you should check your phosphates and magnesium, those electrolytes and all, LFT and all those things as a baseline.
Okay. And
Continue.
assessment. Yes, pre-albumin is the best most widely used one, and nitrogen balance is very sensitive, but it requires 24-hour urine collection, which is difficult. So pre-albumin is most commonly used, and albumin can also be used, but it is it changes the changes. It takes very long time, and transferrin can also be used for as an assessment tool. But pre-albumin is the best one, which changes very quickly. And complications related to central line are pneumothorax, air embolism, thrombosis, migration, blockage, and catheter-related sepsis. Feeding regimen complications like excess weight gain and hyperglycemia, cholestasis, zinc deficiency, and abnormal changes in the electrolytes like calcium, phosphate, and zinc, and refeeding syndrome. And short-term complications like glucose abnormalities, as I said, sudden hyperglycemia during infusion, especially if it is too fast, and hypoglycemia when this stopped it is suddenly. And volume overload, which is measured generally by if it is greater than 1 kg, we can suspect there is a volume overload. And adverse reactions to the lipid emulsions like dyspnea, cutaneous allergic reactions, nausea, headache, and back pain. And cath-related sepsis, infections, and pull out of the PICC lines as soon as possible if suspected any infection. And cath-related pneumothorax, refeeding syndrome. This is a complication in a severe malnourished patient. When you start sudden TPN at a higher levels, it may lead to increase in the sudden glucose high levels, and which release.
It is not on. We know it is not only TPN, either enteral or parental.
Enteral or TPN. Yes. It leads to the sudden release of high proportion of insulin, which leads to the subsequent shift of potassium, magnesium, phosphates into the cells, causing decrease in the potassium and magnesium and phosphate. This lead to sudden electrolyte imbalances, which leads to vomitings, nausea, and the patient may go into death.
Why death?
Due to cardiac arrest.
Why cardiac arrest?
Due to potassium and calcium, these will be fluctuating, and magnesium, which is a cardiac stabilizer.
Fluctuating means what? Hypo or hyper?
Hypo, sir. Basically, hypo.
Yes. Any questions or comments, sir? Anybody has any questions?
No, sir.
Ravi Shankar, sir?
No, carry on. I think, yeah.
Lakshman, sir?
Carry on.
Okay. Go on, Vinod.
Yes, long-term TPN complications. And prolonged TPN may lead to vitamin and essential fatty acid deficiencies. And when we are using 2-in-1 products, it may lead to the, as the fats are deficient, it may lead to the vitamin D deficiency, which may lead to metabolic bone diseases like osteoporosis and osteomalacia. And hepatic complications and gallbladder complications like acalculous cholecystitis and steatosis, and in a TPN in a special population. In renal in a renal patient, generally the proteins which are metabolized into ammonia and leads to formation of excess of urea and azotemia. So to prevent this, generally we provide low and minimal daily requirement of proteins like 0.6 to 0.8. And in a cirrhosis patient, as the urea cycle cannot be happened, and these ammonia may lead into hepatic encephalopathy, with the requirement of proteins should be minimized to 0.6 to 0.8 grams per day. In congestive heart failure, to prevent the fluid overload, we provide high nutrient, low fluid TPNs. In COPD patients, as the because of dextrose, during the metabolism, it provides excess of CO2, and this CO2 leads to brain edema and leads to compromise in the respiratory system. So we provide minimal dextrose and excess of fats and proteins in COPD patients. Continue, sir.
Yes, go on.
Yes.
What is this?
Ceasing
PN.
Parental.
Okay.
This can be parental nutrition can be stopped when the established oral or enteral feeding has been started, and when there is a sepsis in the line, and there is an unresolving acute liver failures. As I said, in the ceasing the parental nutrition, it is important to monitor for hypoglycemia. The parental nutrition should not be stopped immediately. It should be decreased to the 50%, and it is observed for 1 to 2 hours before ceasing. And for the patients on insulin infusion or insulin infusion, the patients require more care as the insulin sensitivity has increased in these patients. These patients suddenly may go into hyperglycemia, and after stopping the sugars, they may suddenly go into hypoglycemia, which is called as brittle hypoglycemia. Can I continue, sir?
Yes.
Nutrition support in sepsis. Nutrition, basically, enteral nutrition can be given in the septic patients if the patient is hemodynamically stable, and it will maintain the epithelial lining of gut, and it prevents the translocation of bacteria. And the nutrition can be divided into acute phase, chronic phase, and recovery phase. And in acute phase, generally the requirement of the body as a metabolism of the body is compromised. It may be almost equal to the basal metabolic energy, and because of the sepsis, the lean body mass like carbs, fats, and proteins, everything start catabolism for production of calories. Even with providing with the calories from the external source, this cannot be stopped. Hence, in the initial acute phase, from the initial 4 days, the requirement should be minimized to around 1500 to 1800 kilocalories. And during the chronic phase, from which is next 4 days, the nutrition requirement may increase to around 2000 to 3000 kilocalories. And in recovery phase, the requirement of energy is multiplied for around 5 times, during which the requirement providing energy should be multiplied into 3 to 4 times. According to the studies, most of the ICU hospitals lag in providing required energy during the recovery phase.
No, I think, wait, man. I don't think, where did you get this information from?
This Vishnair P in nutrition therapy in sepsis.
See, the thing is, I think this, the old technique of chasing the hypercatabolism, giving 4,000-5,000 calories, they used to do all those things. They have very catastrophic effect on the patients. You can't give that kind of the solutions are so hyperosmolar and very, very hygroscopic, it causes massive fluid shifts and cardiac failure and all these things. And they have shown that it is not required to give that. You can't chase, just like you don't chase urine outputs in patients who are post-operative situations. You just give them what is required. You keep them dry, as Dr. Lakshman keeps saying. Similarly, what is called as obligatory
Undernutrition.
Undernutrition. So you just give them 1500 to 2000 kilocalories. See, the thing is, what you have to concentrate on is the treatment of the source of the hypercatabolism, which is usually sepsis or trauma. So once the catabolism comes down, the body will adapt. So you then, the nutrition that you are providing will be sufficient. So you don't go around chasing these things. So maybe, as you said, maybe start off at 1200 calories to 15, go up to 1800 to 2000 calories. So that is about 25 to 35 kilocalories per kg per day. So in a 70 kg person, it will amount to roughly between about 2000 calories. So that is what you need to give. And then if you are, if the patient is in sepsis or in ICU and things, you can increase your protein concentration to 2 grams per kg, or if you are talking about nitrogen, from 0.14 you can go up to 0.19 gram of nitrogen per kg body weight. So and then in patients who are septic, if you are going TPN through the line, you are well advised to reduce the carbohydrate content and give them more of lipid, because the bacteria thrive on the on the glucose that you provide. So by reducing the glucose content and increasing the lipid content, you may help to treat the sepsis also. So these are the required, this one. But this one, I'm not sure that you keep on chasing the,
No, sir, this is
chronic
older recommendations. Current recommendations have changed, as you said, obligatory under nutrition.
Lakshman, sir?
I would agree with it, or whatever you have said. Yeah.
Thank you. Okay, carry on.
Nikita has a question. Vinod, does your regular TPN which you give, will it contain insulin?
No, sir.
Yes. So there will not be any insulin there. So you need to monitor sugars, and if it is high, you need to give insulin as whatever the recommendation is.
Use it on a sliding scale.
Sliding scale. Vinod, I think you should mute your notifications. They keep coming too frequently there. Go on.
Yes.
Yeah.
As in the acute phase, there is a catabolic response in which the body tries to provide the sugars which convert the proteins, fats, and glycogen into glucose, and which leads to excess of glucose, and which cannot be used by the body because of sepsis. So it's better to advise to provide less sugars and sugars as carbohydrates, and to provide high amounts of proteins and fats in the initial part of the time.
How many more slides do you have, Vinod?
Still only 3. Yes, sir.
2-3 slides, sir.
That's fine, because we are already beyond time. So 2-3 slides is fine. Please go ahead.
And nutritional support in acute and chronic pancreatitis. And patients with complicated pancreatitis, generally we provide, historically we force the patient to subside the inflammation. But according to now, the low fat diets within 48 hours are safe in severe acute pancreatitis, and which reduces the multiple organ failure, but not the mortality. And patient with an hepatic encephalopathy, it is better to provide high fat diet. Which
sorry, Vinod, but it is important that you feed beyond the jejunum. Okay, beyond the duodenum into the jejunum. That is important. It is also known that parenteral nutrition, if at all, it's better to give enteral nutrition beyond the duodenum. And if TPN has to be given, It has to be very closely monitored and for a short period and switch them over to enteral feed. Okay. Because it's been shown that the septic complications of TPN in pancreatitis patients is very high. But the feeding must be beyond the duodenum. That is the important point.
Classic Bengmark tube that you put in, which will cause, you can suck the stomach and then you feed through the jejunally placed catheter.
Yeah.
And I think you can start
that
off.
Is where,
almost.
That is where your nasojejunal tube comes in, if you want to start off with.
Yeah.
Sir, for every pancreatic patient, we provide an NJ tube, sir.
No, not for every.
Severe patients.
Okay.
If you are going to start feeding after 48 to 72 hours, you don't have to. Once you know the pancreatitis is severe and the patient is likely to have, for example, goes into ARDS or acute renal failure or needing this inotropic support, all these things. In such patients, you have to start the nutrition. So start enteral nutrition early.
Yes, sir. Continue, sir.
Yeah.
Yes, sir. Continue.
Nutritional support in hepatic encephalopathy. As the liver is not in function, the person lost the glycemic control, which leads to breakdown glycogenesis. The liver control, which is glycogenesis, glycogenolysis, and gluconeogenesis, which is under the control of liver, is lost, and leading to rapid depletion of glycogen stores and increase in the insulin resistance. And patient depends onto the proteins and lipids for the source of energy. And as the catabolic condition, which leads to increase in TNF alpha, interleukin 1 and interleukin 6, which leads to protein calorie malnutrition. And hence, in these patients, we provide high branched chain amino acids, which reduces the protein wasting. And to improve the oral intake, encourage the uninterrupted meals and increase the meal frequencies and decrease meal sizes and fortify the meals with the high proteins. And protein restriction should be less than 40 grams per day before is indicated before invasive measures such as hepatorenal shunts. And if ascites is present, treat with sodium restriction and diuresis and paracentesis. Thank you.
Yes.
What is the most important thing you should remember in hepatic encephalopathy is in patients who have chronic liver disease, if they're diabetic and their insulin requirements start coming down, it is a worrying sign. You have to be worried. And also they can have very, very severe catastrophic hypoglycemia. So you need to be constantly worrying about the sugar. You have to give them continuous sugar, glucose infusions.
Okay.
Anybody has any questions?
Nothing, sir.
Okay. Sir, Ravi Shankar sir, your questions or any comments?
I think, Vinod, the second part was much more coherent and, you understood the aspects better. So certainly a definite improvement from the first class. I think you still read through the slides rather than explaining them, but your slides were good. I think you've done reasonable amount of reading and provided good information. Definitely better than last time.
Lakshman sir?
Yeah, I have a few comments. Generally on the subject of nutrition and specifically on Vinod's presentation. The latter one first. Yes, the second class was much, much better than the first class, I agree. But again, I believe that you people, all of you, must practice it before you actually come and deliver it here. Get your slides ready well in advance and practice in front of a mirror. Time yourself and keep it to less than 40 minutes, because with our discussions and useful interruptions, I shouldn't call them interruptions, but with a discussion, it'll come up to an hour and we should finish within an hour. That's the first thing. But practice is what is important, and I think all of you must do it. Second, it's for the others. We hardly have any questions or any discussion from the students. It must be from the students. We mentors will be overseeing the discussion and perhaps guiding the right direction for the discussion, but we hardly have any discussion from comments and questions from the students, and that must improve. The status quo, the present status cannot continue forever in our teaching sessions. You must participate. Third, I think the others are not reading as well as the presenter, and that is why there are no questions and discussions, and you must come prepared for every class. Even though the presenter perhaps reads a lot more than you, all other students must be reading before coming to the class. This is about the presentation. About the topic of nutrition, the take-home points are very important. Nutrition is something that every surgeon must think about. For every major surgery, I'm not saying you should think about nutrition in sebaceous cyst and perhaps a very common hernia or gallbladder, but if you're doing major operations, a formal assessment must be made. Any one of those several scales that were mentioned, it's easy to do and have an idea of the nutritional status. Look at the possibility of enteral nutrition as a supplement. Understand that there is no ileus in the post-op phase in the small intestine. So get access to the small intestine and do the enteral nutrition. If you do not have access to the small intestine, consider TPN if required. No person should fast for more than 5 days. Remember these dictums, it's very, very important. If you have somebody fasting NPO for more than 5 days, you must consider some kind of nutritional support. It's a very vast subject, and even 2 hours cannot really do justice to all aspects of nutrition. So there are 2 or 3 aspects which we have not discussed, but you guys must go home and read up about. It is the concept of immunonutrition. All right. So it must be understood in detail. So read up about it and see why it is done and where it is done. You must also look at the specialized feeding or nutritional requirements. It was briefly mentioned, not that it was not covered, but you must learn more about nutrition in renal failure, in hepatic failure, in gross sepsis. These are the things that you have to read up a little more about. And things about the practical aspects have to be focused on. Like how do you do a PEG? How do you do an open gastrostomy? How do you place a nasojejunal tube? How do you do a laparoscopic jejunostomy or a gastrostomy? How do you put a central line? Is subclavian line better or internal jugular vein better? You will see that subclavian vein is better. If so, why is it better? So these are practical issues which will come in handy even in your day-to-day practice, and you guys must go and read up about it. If you have any doubts, you can ask any of us mentors and we will help you with it. But these are the topics which were not covered and which I think you guys must go up and read up about. Thank you, Niranjan.
Yes, sir. I agree with Lakshman, sir. And I think refeeding syndrome is also again an important topic for exams where you get it as a main question. And we know only briefly touched upon it. It is very important to know how to prevent refeeding syndrome and how to manage it. So I request all the PGs probably write a answer to that refeeding syndrome.
Yeah, short essay on refeeding syndrome.
Short essay on refeeding syndrome.
Yeah. Good
Other
idea.
than that, I think the same. I agree with the comments from Ravi Shankar sir and Lakshman sir that he's still reading through the slides and he's not prepared. It's like it's not coming spontaneously.
Yeah.
So other than that, the content was good. Okay. So if no other questions, I think we will end it, sir.
All right. Okay. Good
Thank you,
night.
sir.
Good night.
Yeah. Good night. Thank you.